How's it going, guys? We have a medium difficulty question for pulmonary. We've got this patient who has walking pneumonia. We're handing you the diagnosis because we've got an otherwise healthy, youngish patient who just has bilateral interstitial infiltrates with a low-grade fever. And this is usually mycoplasma. Atypical pneumonias can be other things like viruses, Legionella, chlamydia, Francisella tularensis, Coxiella, but mycoplasma tends to be the cause. And 9 times out of 10, it'll be bilateral interstitial infiltrates. 1 time out of 10, it'll be a lobar distribution. But if they do that, they'll tell you that there's interstitial markings and they won't have strep pneumo or staph aureus, which are typical lobar causes. They won't have those listed. So we assume this is most likely mycoplasma. We're sort of handing that to you, but then we're asking you more medium difficulty pharmacology. So what's the empiric therapy here? Choice A, 30S inhibitor can cause ototoxicity is wrong. That's aminoglycosides. Could be gentamicin. Now, we tend to use gentamicin paired with vancomycin as empiric treatment for endocarditis. Gentamicin targets gram-negative rods. Vancomycin targets gram-positives. So aminoglycosides don't have the typical coverage of pneumonias, so the pathogens, the atypicals, strep pneumo. Even though we don't suspect strep pneumo here because it's not lobar, in general, we want to use an empiric agent that can cover all the typical organisms. So aminoglycosides, also gentamicin can be paired with ampicillin, amp and gent. You'll see that combo. That can be used for pyelonephritis. So pyelonephritis, ciprofloxacin, ceftriaxone, amp and gent. I've seen amp and gent on a PEDS form for GBS sepsis in a neonate where ceftriaxone Qbank is wrong. So the ototoxicity can be tinnitus. It can also be the room is spinning, vertigo. And then the nephrotoxicity is acute tubular necrosis. Muddy brown, dirty brown, granular cast. Wrong answer. Choice B, 50S inhibitor can cause gray skin discoloration is wrong. This is chloramphenicol, causes gray baby syndrome. Basically not assessed, okay? I think it shows up once in history. So because it's so obscure and sounds weird, people remember it, but they won't remember like other important pharmacology. But it can apparently be used in the third world because it's cheap and it can be used for meningitis. But once again, pregnant woman takes it, neonate can have blue-gray discoloration of the skin. Wrong fucking answer. Choice C, 50S inhibitor can cause GI disturbance. Correct answer refers to azithromycin. So we use azithro for community-acquired empiric treatment for pneumonia. So it covers the atypicals like mycoplasma, Legionella, chlamydia, even chlamydia urethritis. It's different. That's chlamydia trachomatis, but you can use it for chlamydia pneumoniae as well. And also, it covers strep pneumo, even though that's lobar and we don't expect it here. Even if it were lobar, we would still use azithromycin first line. Now, sometimes you can use doxycycline first line. That's a 30S inhibitor, right? But I didn't list it here because you can't have two potential correct answers. Usually the azithromycin is used over doxy if possible because azithro, it's shorter treatment. Doxy, the tetracyclines aren't good to take with food. Okay, so any chelation with calcium and iron, the divalent cations. So you get poor oral bioavailability. You usually have to take it BD and so twice a day and for a longer duration. For the tetracyclines, not convenient. So we tend to use azithromycin, but it can cause GI disturbance, a bit of abdominal pain, constipation or diarrhea for 24 hours. And also macrolides can cause QT prolongation. So antipsychotics, TCAs, the macrolides, metoclopramide as well. It's a D2 antagonist, same as the antipsychotics, right? So let's just look at the others. Well synthesis inhibitor can cause erythroderma is fucking wrong. That's vancomycin. That's Redman syndrome, actually. So colloquially for soccer moms, you'd say Redman syndrome. That's what shows up in resources, but erythroderma is the medical term. Just diffuse redness. So it's widespread histamine release. Vancomycin, as I already mentioned, can be paired with gentamicin for endocarditis, empiric treatment. Vancomycin can also be paired with ceftriaxone for meningitis, empiric treatment. So you'll see ceftriaxone and Vanc as a frequent combo in USMLE for a lot of things. It's a good combo for community sepsis. Okay, so if you have a nosocomial sepsis, you'd use Vanc, and rather than the ceftriaxone, you could use ceftazidime or cefepime because those have better pseudomonal coverage. So Vancomycin resistance, Diala goes to Diala, D-lac. Sort of sounds a bit buzzy, but you can see that in questions occasionally. Wrong fucking answer. Choice E, folate metabolism inhibitor dual therapy can cause neutropenia. That refers to Bactrim, TMPSMX, trimethoprim methoxazole. Bactrim's used for UTIs. It's also used as the prophylaxis and treatment for pneumocystis jirovecii pneumonia, which is actually bilateral and ground glass pneumonia, but that's going to be immunocompromised patients, HIV patients, CD4 under 200. Bactrim's also used as the prophylaxis for toxo when you get a CD4 count under 100. If you're on the prophylaxis already for pneumocystis, CD4 of 200, you have two birds with one stone, but sometimes patients aren't. If a patient gets toxo, however, the treatment is sulfadiazine pyrimethamine, not trimethoprim sulfamethoxazole. They make that distinction on one of the 2CK forms. But neutropenia, mouth ulcers, this shows up for TMPSMX on one of the forms. You gotta know that. So neutropenia, you think drugs like methotrexate, clozapine, the antipsychotic ultra yield, propylthiouracil methimazole, the thionamides for hyperthyroidism. Ganciclovir can do it, but Bactrim shows up on one of the forms for it. Wrong fucking answer. You know the deal. When you make more content, subscribe to my channel. Appreciate your time. That's it.